What happens when an ICD is just skin deep? Well, we have a approved subcutaneous defibrillator and a state-of-the-art paper on the subject, and that's the April 26th issue of JACC, the Subcutaneous Defibrillator, a review of the literature, and I'm with Dr. Mikhael F. El-Chami, who is an MD, and he's assistant professor of medicine at Emory University, where he's also the medical director of the Arrhythmia Clinic in Atlanta. Now, the device first that we're talking about, describe it just so that we all are on the same page.
So the device is a new technology that was approved in 2012. It's larger than the traditional defibrillator, but it has a peculiar location. Instead of being by the shoulder blade, it's really on the lateral aspect of the chest, with a lead tunneled under the skin parallel to the sternum. The implantation process involves 3 incisions, 1 incision below the breast and a pocket that's created between the anterior and the mid-axillary line. With a lead, the function of this lead is to sense and defibrillate, and it's tunneled lateral to the sternum.
Now, because of its placement, is it essentially the same when it goes off? The patient feels exactly the same as a regular, or is it really a different feel too when it discharges?
A shock is a shock. It's always unpleasant. Typically patients describe it like a horse kicking them in the chest.
Correct.
And it's the same description, again, seen with the subcutaneous defibrillator.
Now, there are some advantages and some disadvantages. What are the advantages?
So the most important advantage of this device is that it does not rely on any transvenous leads. Traditional defibrillator rely on a lead that's advanced through the subclavian vein down into the right ventricle. That's associated with acute complication and long-term problems. The acute complications are hemothorax, pneumothorax, pericardial effusion or tamponade, and the long-term complication is associated with an indwelling lead in the venous circulation that would basically put the lead at risk of fracture. Also, another important problem with transvenous leads, anytime you have an infection or bacteremia, it's a problem similar to endocarditis and the leads need to be removed.
So what are the disadvantages?
Okay. The disadvantages, number 1, it's a new technology. Sometimes with a new technology you find out problems later. But the most important disadvantage of this defibrillator is, number 1, it doesn't provide any pacing. So this is not for patients with heart block or sinus node dysfunction. Number 2, since it doesn't provide any pacing except after a shock, is that if you have ventricular arrhythmia, you cannot provide the anti-tachycardia pacing that could terminate VT in a significant percentage of patients.
So who would be the optimal patient population?
That's a very good question. The optimal patient population are young patients. Young patients are expected to outlive their lead. By 8 years of having a defibrillator lead, 40% of patients will have some kind of a problem with the lead. Young and active patients also predispose the lead to fracture. Number 2, patients with venous problems. So if you think about dialysis patient, they don't have good venous access. Usually the veins have been used for dialysis access. And also immunocompromised patients, which include dialysis patients. These patients are predisposed to infection. So anytime you have an infection, pocket infection or bacteremia, that's a problem when a transvenous lead is present.
Now, the first FDA-approved device was only about a year, maybe 2 years ago max. I remember talking about it in our publications. In terms of what's coming next, are there design elements that can be improved upon? Are there next generation units that could answer some of the problems that we talked about?
That's also an important question. There is the biggest advancement, I believe, will be in battery life. Right now, the battery life is around 5 years. We're not sure. It seems that with the new generation, the battery life is going to be 7 or 8 years. Number 2, the size of this device. This device is almost 1.5 to 2 times the size of a traditional defibrillator. The newer subcutaneous ICD probably is going to be smaller in size. Another important advancement that could come down the road is a remote monitoring capability, which is seen with the traditional transvenous device, but we cannot do it right now with the subcutaneous defibrillator. As far as pacing delivery, I'm not sure. That might be way down the road.
In terms of the percentage of patients who might be candidates in a typical practice, who would that be? How many?
That's an important question. I've been asked this before. Some people say 5%, some people say 20%. I think you have to think about it anytime you have in mind that the patient's going to outlive the lead. So that has to come to mind. Number two, you have to make sure there's no pacing indications. Number three, you have to make sure these patients are not predisposed to ventricular tachycardia, such as sarcoid patient or ARVD. So right now, I think young patients, dialysis patients, patients immunocompromised, this device, they should get it. The rest, it's unclear. Could it be 5%, 10%, 20%? I don't have a good answer for it, but definitely an implanting physician should think about this device anytime you have the characteristics we just mentioned.
So the subcutaneous ICD paper is in the April 22nd issue of JACC. Please take a look at that. And for CardioSource World News, I'm Executive Editor Rick McGuire.